introduce himself in general, but as everyone knows, this is David Hanson. That's brother, who is a malpractice attorney. He generally does defense cases, although occasionally only defense. But he has so he's based in Atlanta, but he travels across the country for depositions and trials, and he's deposed some pretty big names in our field as expert witnesses and otherwise. So he's going to share some of his insights, experiences in some cases he's working on, and talk about some pitfalls. So,
yeah, absolutely. Thanks for having me. I have graduated law school in 2009. I've been an attorney for 10 years. I've been doing exclusively medical malpractice defense for the last 6. It's about 90% of my caseload. At any given time, I probably have 30 cases going on. We represent range. We do some ER work. I'd say about 40% of my caseload are emergency cases, 20% are OB, and 20% surgical of some form, usually general surgery or ortho. We have a lot of ortho clients, and orthopedists get sued a lot. And then the rest is just general hospital work. So we're based in Atlanta. We represent some of the bigger hospitals in Atlanta, Grady. I have a lot of residents through Grady that we unfortunately have to help get out of cases. Piedmont Hospital in Atlanta and some of the bigger groups there. We represent Apollo MD, or Apollo Group, which is a large group with a bunch of ER physicians all over the place, but we represent all their Atlanta physicians. I travel around for expert witnesses, expert work. We try and hire experts, the best in the field. We try and usually split it up with one academic expert, one local treating ER physician. So one run-of-the-mill line ER physician, and then one guy who teaches and researches and things like that, so you get a little bit of a different perspective. This is our firm. Not that you guys need to use us ever, but if you're in Atlanta, Weathington McGrew, this is what we look like. And so I'm here to talk about malpractice cases. The number one question I get from every single physician that I meet is, how do I keep from getting sued? What can I do? My answer is simple. Retire now. There's nothing you can do to keep from getting sued. Then you should move to Aruba because you can't get served outside the country. And then you should wait at least 3 to 5 years because there's a statute of limitations. So even if you're retired now, you might get sued 3 to 5 years later, depending on where you are. The point being, there's nothing you can do to keep from getting sued. I took Dr. Rosen's deposition, Rosen's Emergency Medicine, out in Tucson, Arizona. He has been sued 7 times. He has settled, paid out 2 of those cases. He didn't think he was negligent in any of those instances, but he realized that the risk of going to trial wasn't was too big, so he settled. So the person whose name is on your textbook, I don't know about nowadays, but at least on Rosen's, he has been sued 7 times. So don't worry about it, it's gonna happen. The best thing that you can do is prepare for it. Medical malpractice is a booming industry on the plaintiff's side. $3.8 billion were paid out in 2017 alone. That's $11.57 per citizen, or per person in the United States. It's an increase since 2015, and it keeps going up, it keeps going up. When you move out into practice, and when you get to whatever state you happen to be going to, get involved. The best thing I can tell you to do is get involved with tort reform and get involved with ways to try and fix the system, because the system we have, it doesn't really work. It's difficult, and what you get are millions, billions of dollars getting paid out. I don't know why there's a picture of a little kid. So, payment amounts by the malpractice allegation. So this is what they've alleged went wrong, what type of error, and how much is paid out for each one of those. The biggest one and the biggest concern for you guys is going to be a misdiagnosis, a diagnostic error, or a treatment error. Medication errors happen, they're pretty rare. Monitoring, pretty rare. Surgical, y'all probably aren't going to have to deal with that, but we see surgical complications quite a bit. But for the most part, and primarily for emergency medicine, it's going to be misdiagnosis. Pursuing the wrong path and the patient dies because you messed up. That's probably the biggest thing that y'all are going to have to be concerned about going forward. So by severity of outcome, it's mostly death and permanent injury that creates the payment. I mean, these are payments. So 31% of the payments go to death and significant permanent injury. Long-term injury, you're actually better off killing your patients than you are maiming them, because then they have a life care plan. I'm kidding, but like, then they have a life care plan that was supposed to be funny. And they need constant care over time, whereas if they're dead, there's no need for fixing their house and making it wheelchair accessible and things like that. The biggest payment that our firm has handled was confidential, but it was a girl who basically lost all 4 limbs to a flesh-eating bacteria after she jumped into a river, cut her knee, came into the ER 3 different times. It wasn't sufficiently cleaned out any of those 3 times, and the 3rd time they figured this is a little worse than we thought it was. They didn't get ID involved, infectious disease involved, until the 3rd time. She became a quadriplegic, and she received a lot of money. So what will happen when I get sued? So the broad overview of the case is a plaintiff, there's a defendant. It's civil, not criminal. Where you live or where the incident occurred, that's where the venue is going to be, where the case is going to be. You get sued, you're going to get served. You're going to get a document. Not a big deal. Call your malpractice care. They'll assign you an attorney. Sometimes if you've heard of attorneys in the area that you work or you've worked with an attorney before, you can request that attorney. There will be discovery. We'll exchange documents. I'll ask the plaintiff a bunch of different questions. They'll ask you a bunch of different questions. Basically, they want to know what your CV is. Have you ever been sued before? Did you pass your boards on the first time? Where'd you go to residency? Where'd you do any fellowships? Were you the chief resident? This, that, and the other. Where have you worked? What have you done? Okay, they just want to figure out what the deal is with you. Then there's going to be a deposition. They're going to sit there, an attorney will, and take your deposition. This is the most important part of the case. If you can't defend what you've done, don't expect anyone else to. I have to go out and get experts, and I give them the records, and I say, hey, this is the case. What do you tell me what you think here? I can find experts to support someone in 80% of the cases that I get. But the physician feels bad most of the time and can't defend their own care, or they didn't document well enough, so they don't know what's going on 2.5, 3 years later. They can't figure out what happened. They can't defend themselves, and if you can't defend yourself, there's nothing I can do to help you. So that case is going to have to get paid. Eventually, trial. Only about 10% of our cases go to trial. We have in our firm about 400 active cases, and we try about 1 a month. Most of them, I'd say 50% settle, there's a payment made. 40% go away for some other method. We win on summary judgment, we get it dismissed, they mess something up, and then 10% of them go to trial. We have a pretty good track record at trial. We have lost 3 cases in our last 6 years out of about 30 trials. We defend good medicine, and juries are pretty receptive to physicians. They want to believe that you did a good job. They want to believe that their doctor is doing a good job. So if you can document enough so that people can see why you did what you did, you're going to be in a good space. The jury of your peers, that's what everyone tells you you're going to get. So the Constitution guarantees you. It's not what you're going to get. You're going to get a jury of your patients. That's who the population is going to be. It is drawn from the area where the trial is occurring. So I always tell physicians this. They come in, they're like, well, anyone who looks at this is going to understand what's going on. I'm like, well, how would you explain it to a patient? How would you explain what you did to someone with no medical background who is coming in off the treatment and is coming in for treatment? Because that's the way you need to be prepared to explain it when you come to a trial. What can I do to avoid a lawsuit? The practical part of the presentation. There's a bunch of common causes of malpractice litigation. The number one is bad outcomes. Bad outcomes are unavoidable. And families, they have a bad outcome. A relative dies at the age of 50 after going to the emergency room. They feel like someone did something wrong. That's totally natural, and they go seek an attorney. We see a lot of cases that are simply good medicine, bad outcome. There's nothing you can do about it. You can't do anything. You can treat the patient. You can make the correct diagnosis. You can do nothing wrong. Someone is going to find someone somewhere who's going to say you did something wrong. Bad outcome is the number one cause of malpractice litigation. There's nothing you can do about it. So worrying about the things that you can control, that's what I would counsel to focus on. Poor communication. Most of our ER cases, there's a failure to communicate somewhere. And it's usually the triage nurse, the charge nurse, the the nurse with the patient and the physician charting different things. The triage nurse has this in her chart, has chest pain in her chart. The ER physician got abdominal pain in the chart. Which one is right? And where did we talk to each other? Did I document? I talked to the triage nurse and she said chest pain, but that's just because she wanted to get back to a bed, and really it was because she was nauseous. Okay, that's fine, but when you look at it in the vacuum, when you look at it on the back end 2 years later, the only thing you see is what's charted. You don't see the benefit of that communication, that conversation between the charge nurse and the physician, or between the nurse who's making rounds on the patient and the physician. So having that communication breakdown is one of the largest causes of malpractice litigation. Bad charting. And it kind of goes hand in hand. If you don't document why you've done something, I can't then defend why you've done something. It is important to put your reasoning in the chart. It's not important to get the right result. It's important to say why you did what you did. From my perspective, from a malpractice perspective, you're going to make mistakes. You're going to go down the wrong path. You're going to think that abdominal pain is appendicitis, and it turns out it's not. You're going to think that it's food poisoning, and it turns out it's appendicitis. That's fine, but talk about why you're doing what you're doing. Did you order an abdominal CT? Why? Why did you do that? Did you not order an abdominal CT? I didn't think the abdomen was surgical. I didn't think we needed to go get a general surgery consult. Fine. Document why. No rebound tenderness. The labs weren't elevated. Whatever it is why you didn't pursue that route, put it in the chart. This is probably underrated as a cause. I have had patients who filed lawsuits and settled for pennies on what they were probably likely entitled to because they liked their doctor. One specific case, a woman was going in to have a portacath removed. She was at the end of her life. She was stopping her chemotherapy. She was tired of it. She'd been treating with this physician for 5 years. He goes in to remove the portacath, doesn't communicate with the anesthesia team. Cut bovie. They had used an alcohol prep, hadn't dried. Boom! Burns her face. All right, that's clear negligence. All right, that should never happen, ever. This woman, 2 weeks left to live and has to live it just burnt and in the hospital. She loved her physician. She told all of her kids, do not sue him. I don't care if he did anything wrong. And I liked him, and she was on record as saying that because she liked her physician, they ended up settling the case for $25,000 pre-suit. No lawsuit was filed. Bedside manner makes a difference. If they think that you did the best that you could do for them, when they looked at you and the family was there, it's mostly the family because most of the time the patient is going to be deceased. If the family thinks that you cared, they're going to be a lot more hesitant to go after you than if you were rough, if you brushed them aside, if you didn't pay attention to them. Responsiveness. This is less of an issue for emergency, it's more of an issue for people on consults. I called the doctor, didn't respond. I called the doctor again, didn't respond. I had to call his cell phone and then text him, and then he called me back and said, I'm at dinner, can this wait for another hour? Things like that end up in the chart because someone's trying to cover their butt, and they get you in trouble. In the emergency room, what I would say is when you're trying to get a consult, when you're trying to get a patient admitted, when you go out there at the rural hospital and there's no hospitalist service and you've got to call the local general practitioner to get someone admitted to the hospital, be nice. But at the same time, be firm. And if you think a patient needs to be admitted, go around, move to the next person, move to the next person. Communication and responsiveness. Y'all are going to be in the position to throw them under the bus. And I would counsel be kind in your charting of what you say in those situations, because you can easily, by what you chart, get someone else sued. Not everything needs to be written down, and I have some examples of that. Poor communication. I've actually had this case. That's why we lift on 3. You can see the legs and the patient on the floor. I had this case where the nurses that were taking a patient off the table undid the straps before they were supposed to. Patient was strapped at the feet, slid unconscious, slides off, bangs his head on the floor, top of his head. They tell the patient he sues because he has personality changes after getting bump on the head while he was unconscious. It then told him, it's kind of do the right thing, and what do you get for it? If they hadn't told him, nothing would have happened, but they did the right thing. They told him there was a lawsuit. But there's no real excuse for not communicating. Once the patient's like tilted down and he's strapped at the ankles and unconscious, you can't just like walk out of the room and leave him sitting there. Things are going to happen. The jury wants to hold the provider accountable. They're going to hold you accountable. You're in charge. All right, the captain of the ship. You're going to hear that a lot from plaintiff's attorneys. You're the captain of the ship. You're in charge. If the nurse says something, it's your responsibility. So they're going to think that things flow up. Chart specifics as much as you can. Who told you what? Son said this. Mother said that. This is what occurred, and this is why we're doing what we're doing. Who you spoke with and when. Spoke to the family about the mom's condition. Say that. Say when you did that. It's going to be extremely helpful for you later on if you can say, yeah, I went out and talked to the family 3 different times. Call Dr. X aware of status. I see this all the time in charts. And the next question is, what status did you make them aware of? They have no idea. It's the nurse charting. I called the physician and made him aware. Well, of what? What did you tell them? Made them aware of the high blood pressure, made them aware the patient didn't take their medicine, made them aware of late decels. What is it you're telling the doctor? Made them aware of status doesn't do anything. All it does is covers your butt, saying, well, I was letting them know. It doesn't help. What did you make them aware of? What did you tell them? Know your anatomy. This is way more common than you think. I don't know what a back testicle is. I haven't seen one, maybe you have, but I mean, where is the pain? Is it in the back? Is it in the testicles? Is it in the back testicle? What's going on here? We don't know. Make sure that what you're charting makes sense, okay? And this is especially prevalent when you've got these drop-down menus that auto-populate. Depending on what kind of charting system you're going to be going out to, it's going to be pain, and then it's going to be check all that agree, or check all that disagree. If you've got a chest pain patient that comes in at triage, chest pain, you're scared, you do an EKG, and then you get to the drop-down and you pain and you check nothing, that's a problem. Or you pain and everything's checked and you got to uncheck things. That's a problem. Know how your system works. Do you add? Do you take away? Is there a pre-population? If you say stroke protocol, does it pre-populate with patient presenting with and then the list of symptoms that cause you to be the stroke protocol? Because I've seen that happen. That's a case that we have where the charting system is set up to auto-populate patient presenting with stroke symptoms, left-sided weakness, blah, 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 blah. And then the doctor adds on to the end, patient had a headache. And that was actually the reason that they were doing it. They didn't have any of these other symptoms. Well, that gets them in trouble later on when you're saying, when someone's looking at the record, like, look at all these symptoms you charted. Like, oh no, that's just an autofill from the chart. Well, that's a problem. If you're in charge of setting up EMRs, be aware of that because it gets more people than you would think. Be timely. This entry was almost a year later. If you can see down at the bottom, it was July 1st, 2002 for a date of admission of August 27th, 2001. That's not good. That's not good at all. You need to chart quickly. I know that it is difficult. I know that you have other things going on. I know that you are more concerned with making sure your patients stay alive and their progress, their case moves forward. But if you're not charting timely, what's going to happen is the patient is going to turn out to have a heart attack when you thought it was a PE. You're going to have been going down the PE, and the first charting you're going to enter is after the patient has died. And then your charting is going to be messed up. It's going to be looking like you're covering your butt. It's going to lead to you getting sued, not because you did anything wrong, but because you didn't write anything until after they died. And then you can write whatever you want to. So, chart timely. The blame game. Do not do this. The patient CT scan showed persistent fluid collection unchanged since previously. Therefore, it was not adequately drained. Don't cast judgment as to someone else doing something wrong in your charting. That phrase is entirely superfluous to what's going on here, but it got someone a $1 million payment. That's the only purpose that phrase served. Don't point fingers in your charting. There are some very complicating factors to this matter. The first of which is that Dr. X was the same doctor who had previously removed the gallbladder that he was attempting to remove the second time with this incident. I mean, that's a case where someone's going to get sued, all right? That's fine, but really? Really? Was this necessary? The one down below is a little bit hard to see. Doctor cell phone call, doctor office call frontline, backline only getting busy signal, cell phone answering machine pickup. Later on, finally reached doctor by backline, given report of patient, D-dimer elevated, so on and so forth. Don't editorialize. I mean, I tried 18 different ways and he was out to dinner and I finally, just say what happened. This gets people in trouble. This is more common than you might think. This would explain why she's not any better. I told patient that there may be another disc causing her problem and that would explain why she's no better, that I would examine the various imaging studies and get back to them on Friday. I did not tell them that we operated on the wrong level. Why not? Why? I'm going to discuss this situation with a risk manager and make some decisions as to where we go from here. No, you messed up. Fix it. Tell the patient. You're going to get sued. At this point, you're just making it worse for yourself. Because if I get that, if a plaintiff's attorney gets that and they're sitting across from you in deposition, they're going to have a field day. If you go in and say, I'm sorry, the imaging study actually shows you were at C7, we operated at C4, or wherever it was, we were lumbar and it was C3. We should have operated at a different level, I'm sorry. We're going to go back in, we're going to fix it. I understand if you don't want me to do it, one of my partners will do it, I'll give you a referral to someone else. We're going to do everything we can to make this right. You might still get sued, that's fine, but that ship has sailed at this point. Now you're just going to get hung out to dry in front of a jury, and you're going to get hung out to the dry in a written court of appeals opinion because they're going to be very upset with this. This is the kind of thing that goes in written opinions that are published, that goes in front of the medical board, that gets you in real trouble. I did not tell them we operated on the wrong level. Well, when we saw this case, we were like, first of all, please tell me this doctor isn't still working for you. Second of all, what were you thinking? Documentation. You've heard it. If it's not documented, it's not done. It's not true, but it's the way that people think. It's the way that malpractice attorneys think. It's the way that you're going to get in trouble. Be as specific and concrete as possible. The only thing you have when the lawsuit comes is your documentation. You're not documenting for the purpose of the lawsuit. You're documenting for the purpose of future providers treating the patient knowing it. That's fine. They need the document. They need the information just as much as you are going to need it when you're in a malpractice suit. They want to know your thought process. They want to know why you pursued this, why you went down this path. The closer in time, the better. You remember things immediately. I remember what I had for breakfast this morning. I don't remember what I had for breakfast 3 mornings ago. I'd have to stop, think, and take a lot more time. The closer in time you are, the better your charting is going to be. Quote the patient when you can. This happens a lot. I told the doctor I was having chest pain. Well, actually what you told me is your left lower belly hurts, and when I press on the left-hand side, it hurts there, and when I moved up to your rib cage, it didn't hurt as much. Quote the patient. Quote what they said. I had bad fish last night. I think I'm having a reaction to that. That's why my abdomen hurts. Okay, well, if they tell you that, then you're not thinking appendicitis, and then you can explain why you weren't thinking appendicitis. Well, they said they had bad sushi. They thought it was sushi. That's what they're telling me about, and so that's why it's there. If you write that down, it helps. Appropriate, necessary details. Don't editorialize about other people screwing up, but give the details that are necessary. I called the doctor is fine. I called the doctor, and he never answers the phone when I call him. That's not okay. So give the right details, give appropriate ones. Do not, whatever you do, use derogatory terms to refer to your patients in the charting. This happens more often than you would think. Medical practices that have nicknames for patients. Jane the pain in the ass, who has become Jane pain in the ass, where they try and redact that from the record. They're sending memos around about Jane's calling again, and it's Jane pain in the ass. It's like, you can't do that. You can't do that. There's a case that's recent in Georgia reported in the Court of Appeals and has made the rounds quite a bit of, this is an ER doctor who's calling to get a patient admitted, calling to a hospital that's on service. Hospital just doesn't want to take the patient. Calls again, hospital just doesn't want to take the patient. Calls again, hospital just doesn't want to take the patient. The things are happening and the patient needs to be admitted. Eventually, instead of staying in that hospital, they transferred the patient to Midtown Atlanta. This was a rural hospital. Transferred him, got him, life flighted out. The patient still didn't make it in time. The hospitalist, in the charting, okay, this derogatory term for an Asian person is not taking the patient typical. In the charting, okay? They saw that and they thought, there's got to be more going on here. Text messages the next day about that doctor who didn't take the patient. Yes, the two physicians texting back and forth. What happened to that patient after I transferred up to you? Unfortunately, they didn't make it out. That doesn't surprise me. Dr. X wouldn't take the patient even though I tried over and over again. That's not a surprise. She's a disgrace to my race, and I'm sorry to call her. Horrible. And then it's quoted in the court of appeals. Don't do that under any circumstances. The EMR might look fine on the screen, but it looks horrible printed out. If you've never seen a printed EMR, print one. Go print one. Go find a patient, print the EMR so you see what it looks like. It is horrible. You can barely understand what is going on. Know that so that when you're charting, you know what the things are going to look like. You know where you can enter your narrative. You know where you can type things out. Drop-downs and autofills are the worst. All of these things become evidence. This is all that goes up on the screen in front of the jury. This is what you're going to have. Each time you're at bedside, document. I know it's hard, but when the only thing in the chart from the ER physician is the initial assessment and the disposition 4 hours later to send the patient home, it's really difficult to defend what happened in the meantime. Sure, you're busy. Sure, you've got other patients, but you are rounding. We've all seen the ER. You can see every single one of your patients. It's not like you're ignoring them. You wander around, you check in, hey, how are you doing? That sort of stuff. It's hard to document. I stuck my head in and said, hey, how are you doing? But each time you go in to touch the patient, document it. Try to document it. You're not going to be able to do it, but it makes it so much easier on the backside. If it's midnight presentation, 1 o'clock reassessment, 2 o'clock poke my head in, vital signs were still good, 3 o'clock vital signs were still good, 4 o'clock sent her home, 6 o'clock she has a PE and dies at home. It's a lot easier if you were there 4 different times than if initial assessment and discharge are the only charting entries. Narratives are best. Please explain what you're doing. Document your interpretation of tests and labs when possible. Communicate your plan for discharge. So, what does a case look like? This is the fun stuff. Case 1. That didn't work very well, did it? It's not working at all. It's back. I don't know why. I will tell you what's going on here, because I remember. No, it's showing up over here. So this is a 58-year-old woman presents to the emergency room with history of hypertension and vomiting. She was upstairs visiting her husband in the hospital when she suddenly became nauseous and came down to the emergency room. I don't know why it's not working. Yeah. It is very weird because it shows up on the I'm going to go back and continue to read it. The doctor's charting. Sudden onset vomiting and abdominal pain, was upstairs visiting husband in hospital and came to ER. Okay, that's the ER physician's documentation. The triage nurse's documentation. 5 of 10 pain, location back and shoulders, started to have headache and back pain, felt nauseous and vomited 3 times. Triage vitals, 90 over 51, pulse 98, respiratory rate 20. EKG normal, chest x-ray, read by the ER physician, slightly wide to medium sternum, likely due to portable chest, that's what he documents. Later overread by radiology as normal. What is in your differential? And what do you do next? What's your order? This is the interactive part. CTA, aorta. CTA, the aorta. Ultrasound. Okay. Patient presented at 10:30. Doctor sees patient at 11. Chest X-ray read at 11:25. Lab comes back at 12:45. Normal. Orders a CT abdomen pelvis with IV and PO contrast. You wouldn't do this now, but this was 2009, so IV and PO contrast is kind of the standard order. But my understanding is you wouldn't do this anymore. Entered at about 105. Vitals at 1150, kind of normalized a little bit, 119 over 43, which is a little low, 6320, so the heart rate's gone way down. And they're around that the rest of the night. 335 CT comes back showing what? An aortic dissection. Correct. Abdominal aortic dissection, because he only did abdominal pelvis CT, not a CTA, not a chest, has to immediately order a CT of the chest, shows the arch is involved, gets CT surgery involved, transfers the patient for surgery, patient arrests and transport, dies. So that's what happens. That case is there because the doctor documented the white and media sign. If he had just kept his suspicion to himself and waited for radiology, there would be no lawsuit. He was correct in his thinking that this patient is having a vascular emergency. I mean, a hypertensive, chronic hypertensive patient coming in with a 90 over, what was it, 50. Something's wrong there, right? He was correct in that it was located in the abdomen at the time the patient presented. That's where the dissection was occurring. That's where the pain was occurring. That's why it was. He probably didn't order the right test. Instead of getting the CT of the chest, he got the CT of the abdomen and pelvis. There's a dispute. This case is actually going to go to trial. We're going to try this case because there's some testimony from the CT service there that the average time from presentation to the hospital to diagnosis of aortic dissection in this hospital system is about 20 hours. This diagnosis was within 6 hours of the patient presenting to the emergency room. He made the right diagnosis. He got the right people involved because he didn't document what was on his differential. He didn't document a differential at all, and he didn't document any reasoning. I can defend this, even though it was probably the wrong test order. I can defend that. I can defend why he did it. If he said, I thought the patient was having a AAA, I thought it was abdominal oriented because of the abdominal pain. I didn't get a history of chest pain or back and shoulder pain. I talked to the triage nurse, and when talking to the patient, it was actually abdominal pain, it wasn't back pain. If he documented that, which is actually what happened, if he'd written that down, there'd be no lawsuit. But he didn't write any of that down, so we're having to go back and recreate his differential. Recreate. Well, what'd you have on your differential? I had AAA, I had mesenteric ischemia, and then I had aortic dissection as my third. I thought it was a vascular thing oriented in the stomach, which is why I did the abdominal pelvis. I didn't do a chest because I don't want to expose patients to too much radiation. I want to focus on the part that I think is at issue. If he'd written all that down, there's no lawsuit. This is one of my favorites. A tale of two patients. Patient one comes to the ER at 1 o'clock in the morning on Christmas complaining of vomiting blood. EMS notes 30 grams of coffee ground emesis were found in a can at home. The doctor checks labs, they're normal, gives an IV bolus and Zofran. Patient feels better at 3 a.m., discharged home. 7-year-old son crawls into bed with his mother at about 5 a.m. on Christmas morning. He couldn't sleep, he was ready to open presents, but mom wasn't ready to get up, so he crawled in bed. 6 a.m., wakes up to the gasping sounds of his mother. Calls EMS. They arrive. She's dead. Autopsy shows 750 milliliters of blood in her stomach and a ruptured gastric ulcer. How much are you paying this 7-year-old son who's ruined his Christmas for the rest of his life because he found his mother dying, gasping in bed? Open the checkbook. As much money as you want. Patient number 2. Known frequent visitor to the ER. Shown up 26 times in the previous year. Actually, it's shown up 450 times in the preceding 8 years to this one ER. History of pill-seeking behavior, also a known history of gastric ulcers. Comes to the ER with complaints of vomiting, coffee ground emesis, 30 milliliters reported by EMS. ER orders an IV bolus, Zofran and labs. Hemoglobin comes back at 12.2. Doctor checks labs from the visit 1 month prior where he had admitted the patient for a gastric ulcer endoscope. The hemoglobin in that admission was 8.6 on admission and 10.5 on discharge after a 4-day hospital stay. Patient presents 10 out of 10 pain, discharged by the doctor. 0 of 10 pain without any pain meds. Receives an order from the physician to follow up with a GI doc within 3 to 5 days. These are the same patient. This is the same case. This is a documentation issue. The doctor knew the patient. He was the one that admitted her for a gastric ulcer 1 month earlier. He knew exactly what was going on. Her ulcer was acting up again. She'd had ulcers for 4 years. She'd been seen by this physician 10 times that year. She had been scoped literally a month earlier, and the scope results, if you look back at the results of the scope, they're not concerning. They're not concerning for a rupture, right? So he does this, he checks her hemoglobin. That was the best hemoglobin she'd had the entire year. She'd had her hemoglobin checked like 20 different times that year. That was the best one she had. He didn't scope her because it's 1 o'clock in the morning on Christmas, right? He's not going to call in a GI doctor to scope her when he knows what's going on. He didn't do anything else because he knew what was going on. He didn't document any of that. If he had documented that, there's no lawsuit. Because he didn't document that, this inflammatory complaint, inflammatory case goes forward, and that's where I am. Document why you do what you do, because it's going to help document what decisions you're making. I'll leave you with this. Bedside manner matters. Bedside manner. Get close, talk to your patients, because that's the one thing that is going to keep you from getting sued when you mess up, is that they like to. The other thing is that once you get sued, make sure you have your documentation in order. Any questions? I'm happy to take questions. I think I've gone a little over the time I was supposed to. I can give you many more stories, but we'll leave it there.
For that aortic dissection case, if you would have, like, after the patient was transferred, gone back and wrote more about your medical decision making, would that be okay? Like, presumably if this patient was kind of sick, the doctor wasn't documenting like throughout the whole stay, or is it once the patient is like,
yeah, so I mean, if
going back and say
the doctor made the right decision, right? He made the right diagnosis. So when he makes that diagnosis, go back and write why you did what you did in the first place. Say, I thought this was abdominal because, yeah, so like this was actually a paper chart. So this 2009, it was a paper ER chart, which was phenomenal, which is very helpful as opposed to the chart now. But yes, like if he had waited until after the patient died to go back and chart, that would have probably been a problem. But if he's timing his entry at 4:55 while the patient is going to get a CTA, this is what's going on with the patient. A little narrative. Patient came in presenting with this, originally did this, ordered abdominal CT because I thought AAA. Turns out it was aortic related, but it wasn't a AAA, it was an aortic dissection. Had to get a CTA because we had to see if it was type 1 or type 2, and was surgical or non-surgical, and so on and so forth. So, you know, nobody is critical of anything that he does from getting the diagnosis on. Right? There's some delays that are pretty normal. They're critical of the original order. It's actually an interesting case. The two academics, one head of UC Denver, or Denver's residency program, the other head of Brigham and Women's residency program, are on other sides of this one. And that's fun. So yes, to answer your question, if he had documented while the patient was still in his ER, yes, that would have absolutely helped and prevented him from getting sued.
Is the physician as the leader of the team responsible for delays that happen out of his or her control? Like you order CT, but the CT is having some other patients, or you order a patient that's not given a few hours? No,
but so one of the biggest issues in this case is the CTA, or the CT abdomen pelvis, was ordered at 1:05 in the morning, but it wasn't performed until 3:55 in the morning. And the big issue is why? Because this is a delay case. The testimony is that if we'd gotten this patient on the table at 6 a.m. instead of at 8 a.m., we would have been able to operate and save her life. But the transfer didn't happen for various reasons that were beyond the doctor's control until 8 a.m. Well, that delay was mostly because you give a nauseous patient PO contrast. Like, that's going to take a while for them to get down, and then after you get PO contrast, you got to wait an hour before you scan them, right? So that's why the delay occurred, but that's not none of that is written down. I have cases where stroke patient comes in, no stroke is called because they're not exhibiting classic signs, right? They're totally nonverbal, much more of a nonverbal and kind of combative, more of a drug interaction presentation than a stroke presentation. They're able to stand, they're able to fight back and push. They don't want to be on the stretcher, they want to get up, but they're totally nonverbal. When he was having a stroke, a massive stroke, so they ordered a CT immediately, but no stroke protocol was called, so the CT wasn't done within 30 minutes as the protocol says. It ends up the CT is not done for 2 hours. Then it's not read for another 2 hours, okay? And nobody knows why that happens. But the doctor is responsible for not, in that case, the allegations, the doctor didn't call stroke protocol immediately on a patient presenting with possible stroke symptoms. Our response is, well, I mean, any nonverbal patient has possible stroke symptoms under your theory, and we're not calling stroke alerts on every patient who comes in nonverbal. And we're fighting about that, but we're not fighting about the doctor's delays. There are things that everyone recognizes are outside of your control, okay? Transfers, you can't, did the EMS get here or not get here? Like, I can't control that. Entering orders, you enter it and then you have to wait for the secretary to put it in, and then you have to wait for radiology to send someone over, depending on the ER. You're not necessarily always taking the patient to the CT, walking with them down there, right? You're waiting on the radiology tech to come over and get the patient. They were busy, there were 3 people behind them. And that's the kind of thing where it's hard to recreate in the retrospective. You might have 4 much more critical patients than the one that gets you sued, who are in front of them in line to go get the CT, all right? And it might take you an hour to get a CT on a patient that ends up having a pulmonary embolism and dying in the emergency room. Well, if you had 3 trauma patients that needed to get in there, that's different. So delays, there's a lot of different reasons for delays. If it's a known thing that, nurse had to enter, we had to wait for radiology, not worth documenting. But if it's an easy thing to document, this is why it took so long, that's not a bad thing to say. Yeah.
Yeah, I'm sorry. There's a bunch of things happening today, and your flight.
My flight's at 1:40, so. No, but y'all have to go and dig in the gardens.
That was tremendously interesting. I'm sure everyone got a lot of that. Thank you for coming.
Absolutely, thank you.
And we're going to go straight into the next. Can people contact you with questions
Absolutely.
via email?
Absolutely.
We'll share your